Hi everyone, today we will be talking about progression of air trapping in volume targeted versus pressure targeted ventilation. And air trapping is dynamic hyperinflation syndrome or auto-PEEP. And this is developed in patients with severe airflow obstruction. So if you have a patient with severe asthma or severe COPD exacerbation with chronic bronchitis, what you see on the flow over time in those patients that there is limitation of the flow during expiration. As a result of this limitation of the flow, the expiratory time may not be enough to allow for complete exhalation of the lungs. So what will happen once expiration starts, you can see that the flow decelerates slowly and the next breath may start before complete exhalation, and it will result into what we call persistent flow at end of expiration, meaning that there is still flow at the time when the next breath started. That means that the lung does not completely empty. So the air goes inside the lungs and does not completely empty out during expiration. You can see that on the pressure over time curve by increased initial rise in the pressure because of the auto-PEEP, and then it will be normalized to the peak inspirator pressure before it goes down to the plateau pressure, correlating with zero flow here, and then the pressure goes down to zero at beginning of expiration. If you look at the alveolar pressure, the alveolar pressure is higher at the end of expiration here. It goes to the plateau pressure and then it goes down gradually, but it does not reach the same airway pressure here. There will be a persistent pressure gradient between the alveolar pressure here at 8 centimeters of water and the airway pressure at 5 centimeters of water. And let's just look at it in a different direction. This is a patient who's breathing normally with a tidal volume. This patient would breathe above the functional residual capacity, and he has still capacity here to breathe deeper. He can get a sigh or deep inspiration, so you have more capacity for the inspiration. If you have a patient with asthma, as we already mentioned in the previous slide, this patient will get the air in, does not completely come out, results into gradual increase in the lung volumes. You can see that on the chest X-ray with the hyperinflation. And if you put this patient on mechanical ventilation with a volume control mode of ventilation, the tidal volume will be fixed. However, as a result of the increasing in the residual volume capacity, you will see that the functional residual capacity is gradually increased and the inspiratory capacity is gradually decreased. So there is a reduced inspiratory capacity. This patient does not have a capacity to breathe deeper, and at the same time he's breathing at a very large tidal volume. There is increased functional residual capacity. Now the question is, what happens next? Does it continue to enlarge more and more till it gets to a point where the lungs will rupture, or there is a limit for this process? That's what we are going to explain in the next two slides. We will explain this in two different modes of mechanical ventilation. The first in volume controlled mode of ventilation, and the second is in pressure controlled mode of ventilation. We will be using initial state here that is depicted in yellow on a volume over pressure curve, and you can see this is the compliance curve of the lungs. And this patient is breathing from P1, which is PEEP, all the way to P2, which is inspiratory pressure. In volume control, we need to deliver a fixed tidal volume, which is V1 here. and we start from the end expiratory lung volume, which is V1 in this example here. Now, if this patient is gradually developing dynamic hyperinflation, you will have multiple states here. I'm going to get to the end state where it's depicted in red color here. And the landmark for this would be an increased end expiratory lung volume. This will be gradually increased, as we already talked about it. As a result of this, the PEEP will gradually increase from P1 to P2. However, the tidal volume has to be delivered. This is a volume control mode of ventilation. V1 has to be delivered. Because now we move to the right, look at the compliance of the lung. It is at less compliance compared to the previous one. So you would require a higher pressure. Now the pressure will be the difference between the peak pressure and the PEEP will be increased. You can see that we need the driving pressure higher than the previous case. So the delta P2 is higher than delta P1 in order to deliver the same tidal volume. Now, as we already mentioned, there is a progressive increase in the end expiratory lung volume. This increase will continue until the difference between the end inspiratory and end expiratory, which is the driving pressure, increases sufficiently enough to expel the inspired tidal volume in the same time available. So the expiratory time does not change. However, because of the increasing driving pressure here during inspiration, this alveolar pressure will be high enough to expel the tidal volume in the same time that was available to this patient before all this dynamic hyperinflation started. As a result of this, the process stops and no more dynamic hyperinflation. Now, in pressure-controlled ventilation, it is different than volume-controlled ventilation. As you know, we fix the pressure here, and the tidal volume is variable. So this is the initial state, which is exactly similar to the previous case. However, the mode is different. We give the P2, which is the peak pressure set on the ventilator. The P1 is the same, which is the initial PEEP state. Now, as a result of the driving pressure, which is delta P1, the tidal volume is delivered is V1. Now, dynamic hyperinflation is built up gradually. And what will happen because of the dynamic hyperinflation, the PEEP will increase. So that pressure here, P1, is gradually increased to this level. As a result of this, the end expiratory lung volume will gradually go up. So as we move up higher on the residual volume or the end expiratory lung volume, and as the peak pressure is fixed, the driving pressure is decreasing. As a result of the decreased driving pressure, less tidal volume will be delivered to the patient. Now, there is a progressive increase in the end expiratory lung volume as it is in the previous case. This increase will continue until the inspiratory tidal volume falls sufficiently enough to be expelled by the falling difference between the end inspiratory and end expiratory pressure, which is in this case delta P2. So it will continue to rise till this tidal volume falls, and this decrease in the pressure will be enough to exhale all the air in the same time available for the patient on the ventilator. So I hope I was able to explain this. I know it is complicated, but it's worth thinking about it and understand it. Thank you.